Hi, everyone, and welcome to our webinar on Krabbe disease newborn screening and diagnosis. We hope over the next hour to familiarize you with a number of aspects of diagnosis, screening, and treatment of Krabbe disease. Our speakers are Joe Orsini, who's Deputy Director of the Newborn Screening Program at the New York State Department of Health. And he's going to speak about newborn screening for Krabbe disease, historical perspective. He'll then turn the lectern over to Dietrich Matern, who's Professor of Laboratory Medicine and Pathology and Medical Genetics and Pediatrics, and co-director of the Biochemical Genetics Laboratory at the Mayo Clinic at Rochester, Minnesota. And then myself, who will talk about clinical management of newborns diagnosed with Krabbe disease, diagnosed through newborn screening. And I'm from Duke in the Department of Pediatrics and the Marcus Center for Cellular Cures. Before we get started with Dr. Orsini's talk, I wanted to give you a brief overview about Krabbe disease, just to orient you to the topic. And these are my disclosures. So Krabbe disease is an inherited leukodystrophy that leads to death in infancy or early childhood, and it's due to mutations in the gene encoding galactocerebrosidase. And there have been more than 100 mutations described that cause Krabbe disease. There are three clinical subtypes: infantile Krabbe disease, which presents somewhere between birth and 12 months of age, and used to be called early infantile Krabbe disease. And then later onset Krabbe disease, which can occur in older children between 1 and 3 years of age, in a juvenile form in children 4 to 18 years of age, and rarely in adults who are over 18 years of age. We know from experience over the past 2 decades that therapeutic interventions have the best outcomes if they're administered very early in life. And currently, hematopoietic stem cell transplantation is the standard of care for pre-symptomatic or early symptomatic patients. There are also a few active clinical trials for emerging gene therapies. Currently, newborn screening is available in 10 states. There is an application under review to add Krabbe disease to the recommended newborn screening panel under HRSA, and that will be presented to the panel next week. We also have an ad hoc newborn screening task force that a number of us created that meets monthly to review complicated cases. Clinically, for infants with Krabbe disease, they look normal at birth, although they may have cortical thumbs. They have early feeding problems that are usually misdiagnosed as colic. They develop extreme irritability and cannot be consoled, which is probably one of the most distressing symptoms to their families and parents. They have failure to thrive because of feeding problems. They develop spasticity, which is manifested as stiffness or arching. Ultimately, by 6 to 8 months of age, most babies develop seizures, loss of vision, and loss of developmental milestones. Most families go through a diagnostic odyssey of misdiagnosis, including colic or cerebral palsy or failure to thrive. They're referred to multiple specialists who really take months until an accurate diagnosis is determined. And unfortunately, treatment with transplant is only beneficial if it's performed before significant symptom onset, which really defines the need for newborn screening in this disease. So today, we hope you'll learn that Krabbe disease must be treated early in the course of disease, how to recognize signs and symptoms, the need for newborn screening, some information about how New York State piloted newborn screening for Krabbe disease and the lessons learned from their early experiences, information about how psychosine transformed newborn screening, allowing for rapid and accurate diagnosis of infants with infantile Krabbe disease, and also allowing for identification of infants who are at risk for later onset Krabbe disease, and then some information about the options for treatment of patients with Krabbe disease. So I'm going to stop sharing my screen now and turn the platform over to Dr. Joe Orsini, who will give the first talk.
Can everybody hear me okay?
Yeah,
Okay,
you
great.
need to go into presentation.
Yes, it slipped out of that. Okay, well, thank you very much for giving the overview on Krabbe disease. I have a little bit of that in this talk, but we'll be focusing really on the first years of screening that in New York, which was initiated in August 2006. So this has been something that's been ongoing for quite some time. So Joanne talked a little about this, but the disease was first described in 1916 by Knud Krabbe, and it's since been recognized as an inherited metabolic disorder. It's autosomal recessive, has a incidence reported to be 1 in 100,000, which is kind of being turned around a bit through newborn screening. It's from a deficiency of galactocerebrosidase, and Joanne described how there's varied forms, but the infantile form of disease is still thought to be the predominant form, somewhere in the 80 to 95% of cases falling into this category. So hang on, I think I skipped a slide, sorry. Somehow my thing skipped one. All right, so what I want to mention here is that Hunter Kelly is the son of Jim Kelly, and you'll see this talk was organized by Hunter's Hope. This family is really largely responsible for implementing newborn screening, and a lot of the advances that have been made have been through the help of this organization and organizing all of us scientists and keeping us kind of focused on what might help screening. So I wanted to give them a shout out and the organization for all they've done to advance newborn screening for Krabbe disease. So what constitutes a diagnosis with Krabbe disease? This is true for any autosomal recessive disorder. Typically, you're going to have low enzyme activity, or in the case where you have a patient presenting, there's going to be somebody with clinical symptoms. Of course, with newborn screening, we're talking about individuals with no symptoms, and this is why we screen. So the way we're going to go through a diagnosis with newborn screening is we're testing dry blood spots for low enzyme activity, and then additional testing is done, and we're recommending now second-tier screening for psychosine, which is this main substrate associated with Krabbe disease. And then something that's a little less important now with psychosine, but still helpful in cases where there's potential late onset disease, is to look at the GALC variant testing and get genotyping done. And all of this can really help present a picture of prognosis of a newborn that may have Krabbe disease. So the way the assay works in general is we've got substrate that looks like this molecule here, and the enzyme present in the dry blood spot will actually take off this galactose unit. This is considered, the compound is galactosyl ceramide. So GALC is galactosyl ceramidase, the enzyme that's present in blood. And if it's working, it produces this ceramide molecule, which we look for in a mass spec. This is the method used in New York and many other states currently. But the psychosine is a very similar compound, and the interesting thing about this is turns out to be quite elevated in babies with infantile disease, and we can detect that in newborn screen. And Dr. Matern will talk more about this aspect of the testing with his talk. But I like to comment that this particular compound is elevated in individuals with disease where the galactosyl ceramide is not. And it's an interesting fact that there's something called a psychosine hypothesis. And that is where psychosine is really elevated, and it actually causes the cells that produce the galactosyl ceramide to die through cell apoptosis. So that particular process means if you measure galactosyl cerebroside, the actual galactosyl ceramide, that compound will not be elevated in blood, whereas psychosine would. So this was puzzling for people for a long time, and you'll hear about the psychosine hypothesis as being something that is still thought of as today the cause for onset of disease. So back in 2004 was the very first paper on how to screen for Krabbe disease. And largely this method is what we still use today in New York State and other states that are using mass spec testing. And then in 2005, there was a major report on transplant outcomes for individuals with Krabbe disease. And this is really what the combination of these two things is what's really necessary to start screening, is to have a method to screen and a therapy. So as I mentioned earlier, it started in 2006 in New York State. We used the method that was described by Gelb. This is a method that uses mass spec. And we were initially trying to start screening upwards of almost 300,000 specimens per year. So the laboratory here was set up to run that kind of testing. We had originally had 3 full-time staff when we were doing method development, but we currently can do this with really 1 full-time staff person, and we have a couple of other cross-trained staff because we're doing other testing as well, just to give people an idea of how much work is involved in doing screening. Our current algorithm involves second-tier DNA testing, and as it did when we initially got started, this helped reduce the false positive rate by 40%, which turned out to be okay, but nowhere near as good as what psychosine is able to do, and I'll show you more data on that as we move along. We purchased materials from just a chemical manufacturer, and we did some modifications to the assay. To do this assay, we needed 3 mass specs and 2 liquid handlers and some evaporators. So that was what was required to get us started for those labs that might be having to get started in this in the future. The method has evolved pretty significantly since we got started. When we originally started, we only were able to run, practically speaking, just 1 enzyme, and that was the GALC enzyme. That turned out to be a large reason for, a big reason for all of our positives, was when you look at just 1 enzyme, very often don't know, is there something that's affecting that enzyme other than, maybe having disease. But over time, people were modified the assay a bit to make it more user friendly in a screening environment. And we ended up using the kind of a modified version for several years. And then Dr. Gelb's group published a paper showing you can actually combine Krabbe screening with Fabry. Actually, you can do Fabry, Pompe, and MPS1. And when we saw this in New York, we thought, well, if they can do this combined assay, we should try doing a combined assay. We were able to add a couple more enzymes into a combined assay. Well, eventually, a commercial vendor moved forward with putting a test out, and that was able to run 6 enzymes all at once. And then Mayo showed you can run the 6 enzymes with adrenal leukodystrophy. New York has done the assay with 6 enzymes in adrenal leukodystrophy, and I think that Mayo still does this for Kentucky. But we're really back to using this assay, the 6 enzyme assay. And why it's really important is now we have 5 other enzymes we can look at that really help with improving the assay and give us an idea of, is it just the Krabbe disease enzyme that's low, or are all these enzymes low? And that helps tremendously. So this is just the solutions that are put together for your information. If anybody needs more information on this, you can feel free to contact me. But again, it's 6 enzymes looking for MPS1, Pompe, GALC, Krabbe, Fabry, and human PIC. 3 of these that are here, my MPS1 and Pompe, are currently on the recommended uniform screening panel. The others aren't, but they all become useful reference enzymes in evaluating a baby for Krabbe, if they're potentially positive for Krabbe disease. The assay is fairly straightforward. Take a dry blood spot, add substrate, internal standard, incubate overnight, perform a liquid cleanup. Basically allows you to remove all the protein and salts and things that you don't want from the blood. You can only get the compounds of interest. Then run them on a mass spec, and then we'll follow the screening algorithm that I show you here. This looks complicated, and I'm not going to go into every detail. Essentially, what we're looking for is babies with low GALC enzyme. And then we also look at the other enzymes and compare them and get a feel, is it really low just for Krabbe, or are there a bunch of enzymes low? And it gives us an idea of how real of a case we might think this is. I'll give you an example. Today we had a baby that had activity at about 5% of the daily mean in both the Pompe enzyme and the IDUA enzyme, the one for MPS1, were near 100%. So this baby is actually right now getting samples on its way to Dietrich, his lab at Mayo, for second-tier psychosine testing. And we initiated our GALC variant analysis. So by tomorrow, we'll have GALC variant analysis. Mayo will have a psychosine sample in their hands and initiate psychosine screening. And by Saturday, we'll have psychosine analysis. Depending on the outcome of our variant testing, we'll have a better idea of just how much of an emergency is this sample. So I'm letting Dieter know via this talk that he's got a sample coming. So all the rest of this is really just details, but that's what's going on now. So one of the things I mentioned, or I didn't really mention, but I talked about, is the ability to use all of the enzymes to get a better idea of how real this low GALC sample is. Well, the Mayo group has developed something. They didn't develop it specifically for Krabbe disease. It was originally developed for looking at all amino acid and acylcarnitine disorders, but they've applied it quite well to screening for Krabbe disease. And what that does is essentially take some of the issues that I talk about, compares the GALC results for very birth weight, age, and then ratios to all of the other enzymes, and determines how real is this, or does this look like a Krabbe case, or does it look like a false positive case? Now, I would like to say that you can do this without the clear tool for those that, but the clear tool definitely helps. But all the other enzymes will help people without clear develop screening for Krabbe disease. You'll end up with some more positives, but it's not, since there's multiple enzymes, as long as you use multiple enzymes, you can kind of keep that number down. I mentioned earlier that Krabbe, the GALC enzyme activity in a dry blood spot, is very dependent on birth weight, age, the sample, and collection. And that's going to be due to some variables I'm going to talk about here shortly. But what we observed very early on is that low birth weight babies have activities that are about 3 to 4 times higher than normal full-term babies. We also noticed that the GALC activity is lower in specimens from older babies. So like if there's a baby where we get the first specimen and they're a week old, because maybe it's a home birth, and there's some delays in getting the specimen, actually taking the specimen from the baby, we notice those are almost always lower activity than some sample taken in a newborn period. Or if we get a repeat specimen, the GALC activity is lower. So that's something that can cause false positives if you're just looking at GALC activity alone. Here's an example where I took, say, 4,000 or 5,000 babies, and I sorted on babies with less than 12%, which is kind of our normal cutoff for Krabbe, and got an average of 8.3% on those. But you can see all the other enzymes are actually low as well. And it works the other way too. For when GALC is very high, all the other enzymes are very high. So the clear tool really helps you sort out this sort of thing. And this can be further broken down by birth weight and age. And you'll see sort of similar kind of characteristics, I guess, for the sample. And again, that's where the clear tool can really help you. So why is it that this happens? There's low hematocrit, low leukocytes, all of these combinations, transported conditions, like if the sample's been sitting in a truck in the heat for a while, that would deactivate enzyme. Often we get specimens. We had one the other day that was really low, but when I looked at it, it was like marginally saturating the filter paper. So you can, when blood doesn't fully saturate and fully fill the circles of the blood collection cards, well, that will affect your enzyme activities. And of course, the GALC variants in birth weight and age are other variables that can all affect enzyme activity. Hematocrit is known to be variable in babies as well as leukocytes. And you can see leukocytes actually spike at 12 hours and then drop off with age. And this is kind of what we attribute overall enzyme activity variation. Hematocrit has an effect where it's kind of the thickness of the blood. The more higher the hematocrit, the thicker the blood. You can get an effect where how much blood you get out of a 3 millimeter punch is affected by this. Then there's another contributing factor over here on the right. It was reported in the original paper that there's an inhibitor, and it doesn't say anything about an inhibitor here, but the more blood, if you take a half a spot or a full spot or 2 spots, what you'll see with Krabbe, which is this bottom curve, you get kind of a rollover where the more blood you use, the less activity you get. And I think there's some relationship between that and hematocrit, because we see sometimes really dark blood spots, sometimes might have lower activity, and it's potentially an inhibitor. Nobody's ever proven what it is, but we know this effect is going on. We also know that it's worse for Krabbe disease. You can see it's the one with the lowest activity and the most rollover. So it's the one that really benefits the most from using multiple enzyme analysis. I mentioned before psychosine, how we're sending it to Mayo. This is essential for reducing false positives and highly recommended. Still, the sequencing tests we do here in New York, it works well for us. We're used to it. We've been using it since the beginning of time, and it does provide us with a day faster turnaround. But it's not necessary to do newborn screening, and it should not be an impediment to screening and starting screening in any states. It's not, like I said, when you have low enzyme activity and very elevated psychosine, as Dietrich will show in his talk, I'm sure, that's a real sure sign of an infantile disease. So this was really a critical finding. We've determined this in working with Genzyme, a company at the time, where we sent some specimens off to them to look for psychosine and found psychosine being very elevated. Dietrich and his group with Gunzel and one of their fellows at the time really expanded upon this, and that paper was published in 2020. And then we also have a congruence paper in 2020, and with this paper it was a way of trying to show that no matter what reference lab is actually doing testing, as long as we use calibrators, common set of calibrators that are provided by a laboratory, Dr. GALC's laboratory, all of these labs can end up with the same results. So that's how we've set up the screening, so that we can set these all labs that are participating will get similar results. So what else has happened? So since 2006 to 2018, where we used only DNA, New York's referral rate was about 0.019%. Doesn't sound like a lot, but that, every baby that's a false positive, that's not good when you're looking at a 1 in 100 to 200,000 kind of incidence. This referral rate was quite high. It's about 1 in 5,000 babies. And in New York, that was about 1 baby a week. So it's very high. Using Clear and DNA since 2019 to 21, where we were using the Clear tool and DNA, our referral rate is down significantly, about 1 in 15,000 babies. So 1 every 3 weeks now currently. But we also did a retrospective analysis, and this is where we're moving. We're still a little ways from adopting psychosine fully, but we plan on doing this, and we're also adopting no longer referring babies with only 1 variant. When we go to this, we expect to have a referral rate about 1 in 200,000, which will really improve things in the state. And that's something we anticipate happening within the next couple of years. So this is really an overview of screening. We've up to right now, the number is about 3.8 million. We've just turned over to that number recently. We had 1,055 second-tier molecular over that course of time. It's 590 referrals. This is really old news, and a lot of people will look at this. And I think what you want to really see is what can be done, and with all of the new approaches, and that's something that we described in Dietrich's talk. So our current referral rate is down to 14 per year, roughly just a little more than 1 a month. And it used to be 52, and that did not incorporate any second-tier psychosine yet. We make the next step of that in the next couple months. One thing that's also noteworthy is through the course of all the screening, we found 35 babies that we think are at low risk for Krabbe disease. They're part of the screen positive population. 24 that we think might be at higher risk for a later onset. And then throughout the course of screening, we have 10 that have become symptomatic, 1 that's a late onset, and 9 that are infantile onset. So that's the summary of New York State screening. I'm sure we'll have time for questions later. So I'm going to stop sharing my screen and pass this on to Dietrich.
Thank you, Joe. And thank you, Hunter's Hope, for organizing this presentation. I assume you can see and hear me and see my slides as well. So let's continue on this journey of Krabbe disease, newborn screening and diagnosis. Just to bring us all on the same map, so to speak, this is the current number of conditions that are included in the screening programs in the various states in the United States. And you can see that there are some differences, but most states are at this point screening for the 36 conditions that are on the recommended uniform screening panel, at least based on number. A few are lagging, and some are doing apparently much more even than the secondary targets would suggest. When it comes to Krabbe disease, there are currently 10 states that are screening for Krabbe disease. The last one, the 10th one that was added, was Georgia, which does this at this point as a prospective pilot study. So they do follow up on patients that are at risk of having Krabbe disease. And overall, these 10 states cover a third of the 3.7 million babies screened in the US every year. So newborn screening for Krabbe disease is here. I think for equity purposes, it would be appropriate if the other states are getting on this path as well. So Joe mentioned what they've been doing in New York historically since 2006. This is from a paper they published in 2009 describing the process, where they look first at the GALC activity, and then if that is below a given cutoff, they do DNA testing as Joe described. So, and Joe published this further on in 2016, the first 8 years of screening of how that has been going from the laboratory perspective and what they found in the laboratory in terms of GALC activities and genotypes. And I think one of the things that we learned from that is that you can do comprehensive GALC sequencing. It doesn't favor one ethnic group, but what we also learned, I think, is that the wild type genotype for Krabbe, for GALC, for the GALC gene was really determined in mostly white populations. So a heterogeneous population with different ethnicities would have, as was shown in New York, more genotypes of uncertain significance, meaning that at least one variant of uncertain significance is included. Now, we know a lot about the molecular genetics, in particular thanks to the New York program. Now, if you look, and last time I did, a couple of weeks ago in ClinVar, a repository where all published and otherwise submitted variants in the various genes are listed, there are more than 1,000 GALC variants currently known. And among those, we have 174 that are pathogenic, including a well-described 30 kb deletion. And then there are 129 that we know are benign, which makes up about 303. So about a third of all the known variants, which leaves another 2/3 as kind of uncertain, either likely pathogenic or likely benign, or uncertain significance. We just really don't know. Or there are people who say it is pathogenic, others say it's benign. So that causes a lot of consternation, especially in newborn screening, when you identify a baby that is clinically completely fine at the time and has a genotype and a low enzyme activity and what do you tell the families, and what do you do next? So Melissa Wasserstein in New York City led another effort looking at the first 8 years of screening in New York and published the clinical side of the screening, and really put out a word of caution that the way it has been done in the beginning in New York is probably not the best way of doing so. So a lot of work was done, again, thanks to all the effort that was performed in New York and learning a lot from that project. In 2021, so almost 2 years ago, another nomination was made to the advisory committee on the federal level to add Krabbe disease to the recommended uniform screening panel, or RUSP. And you can see that Dr. Kurtzberg and I were co-signatories on this, along with others. And what is maybe unique, but probably something that you will see more frequently in the future in nominations, is that it's not just about Krabbe disease, but it is about a process of how to do the newborn screening, which really looks to identify those babies with Krabbe disease that need the early initiation of treatment. And making the later onset variants that you may not always identify with the proposed strategy a secondary target in RUSP terms. So we applied this, or maybe spearheaded it, in Kentucky. When in 2015, a law was passed in Kentucky that Krabbe disease should be screened for in every baby born in Kentucky. Our colleagues at the Kentucky Screening Lab were given short notice and basically no money. And so they reached out to us here at the Mayo Clinic and asked if we can help them. And we said we can. And we also then added Pompe disease and screening for MPS I at the same time, and a couple of years later for adrenoleukodystrophy. So that started in reality in February. So basically, what is it, 7 years now almost, that we screen in Kentucky babies, and added adrenoleukodystrophy in July of 2018. Samples are arriving first in the Kentucky Screening Lab from the birthplaces in Kentucky, and then overnight get to us, and then we do the analysis. So what we do, we run a 10-plex assay that Joe mentioned, basically looking at 6 lysosomal enzyme activities and measuring the concentration of 4 lysophosphorylcholines. The lysophosphorylcholines are the markers for adrenoleukodystrophy, and the 6 enzymes clearly include GALC activity, and then acid alpha glucosidase for Pompe disease and alpha iduronidase for MPS I. And then it also measures the activities for acid sphingomyelinase and the enzymes that are deficient in Gaucher and Niemann-Pick AB disease. Now, we're not screening for those last 3 conditions. We're just measuring the activity, and we use that data in CLEAR to see whether the overall profile of those results would fit better with a healthy baby, or possibly with a baby with Krabbe disease, Pompe disease, MPS I, or adrenoleukodystrophy. So we do not apply any cutoffs. So to answer Dr. Friedenberg's question in the chat, if there was low acid sphingomyelinase deficiency activity, we would not see it because we're not looking for it, or CLEAR is not asked to look for that. We could do it as soon as Kentucky said we want to screen for Niemann-Pick, but since they don't, we don't look at those data. I don't want to see it, so we don't call it. We published the first 3 years of screening for the lysosomal disorder several years ago. CLEAR, again, is a bioinformatics approach to looking at the results for those specific conditions that we're screening in Kentucky. There's a secondary tool, dual scatter plots, where you compare, for example, Krabbe versus false positive GALC reduction because of pseudodeficiency or other reasons, poor specimen quality, and whether it could be Krabbe or is a false positive. And if you want to learn more about CLEAR, there's a whole special issue in the International Journal of Neonatal Screening that came out a couple of years ago, where you find a bunch of papers about CLEAR and how it is used. It's a free bioinformatics tool for newborn screening programs. but it does require some effort to submit data and then to learn how to use it. But it's worth it, as Joe said. You just can trust me. Now, after CLEAR, we're not done. We do second-tier tests because CLEAR is not perfect. And so we're trying to reduce false positives using second-tier tests, which we find are cost-effective means to reduce false positive results, especially for biomarkers where you have an overlap between the normal population and the disease range. So we do this after the primary screen, and we do it on the same newborn screening specimen we already have. We're not asking for additional patient contact, additional patient samples, because we do not want to have anyone talk to anyone about Krabbe disease and other conditions unless it's really warranted. And when the second-tier test result is normal, it overrules the primary screen. So it goes out as a normal screening result, and there are several other examples where second-tier tests are very helpful. So again, how does it work? At the birthplace, the sample is collected, the dried blood. It goes to the screening laboratory that does the primary screen with several punches, and if everything is normal, everyone is happy. If something is abnormal and there is an ability to do a second-tier test, you take another punch from the original card, as I said, you do the second-tier test for the more disease-specific analyte, and if that is normal, everyone's happy. No one needs to know about the initial abnormal primary results. And if it is abnormal, you don't have to waste any time. You go right to confirmatory testing. So for Krabbe disease, when we get an informative score for Krabbe disease, we do the psychosine analysis. What is psychosine? Joe mentioned it already. In a healthy baby not affected with Krabbe disease, this enzyme works just fine on galactosyl ceramide, producing ceramide, and then acid ceramidase is chopping off the ceramide into sphingosine and a fatty acid. And when you have Krabbe disease, this enzyme is deficient, and the acid ceramidase now acts on the galactosyl ceramide and produces galactosyl sphingosine or psychosine. So as you can imagine, you have a block here, and this is produced, this will accumulate. And psychosine has been shown to be neurotoxic to Schwann cells and oligodendrocytes, explaining a lot of the pathophysiology and the symptoms that are seen in patients. Apparently, we think it's a biomarker of Krabbe disease, and I think it is, and it's measurable in all kinds of tissues. Initially, in the research laboratories, it was done on tissue specimens such as brain, and then Joe actually was first to show that it can be measured in dried blood spots, and then we took that idea from him and applied it, and eventually started using it when we started screening for it in Kentucky. We also measure it now in erythrocyte. It can be measured in leukocytes and CSF, all kinds of specimens. So psychosine is done. Again, we published that with Joe and others. And just to show you how psychosine behaves in patients with infantile Krabbe disease compared to healthy controls, you can see that in infantile Krabbe disease, it is markedly elevated over healthy babies. In late infantile Krabbe disease, where we have 33, you can see that it's also abnormal compared to normal, but we're getting, it's getting a little bit more, not difficult, but the gap is less. And then in the 4 cases of juvenile Krabbe disease we have, you can see that half of them basically had psychosine in the normal range. Now, these are not all newborn screening samples, so we do not know whether this psychosine would have been higher in the newborn blood spot. You can see babies with pseudodeficiency and carriers that have totally normal psychosine. So if psychosine then is abnormal, elevated in our newborn screen for Kentucky, then the screen is positive. And if it's normal, the screen is negative. Our first baby that was born in the first year of screening in Kentucky, the blood spot was collected on the 2nd day of life. On the 3rd day of life, it arrived in the Kentucky lab. On the 4th day of life, we had arrived at Mayo, where we did the sample prep and started the enzyme incubation. So it requires an overnight incubation. And then on the 5th day, which was a Sunday, we had an informative result for Krabbe disease. At that time, we still repeated just to make sure that galactocephalitis is really low in the specimen, and initiated the second-tier tests because we also do look for the 30 kb deletion, which we did because at the time we were supposed to do something molecular. So we said, okay, we can do this fairly quickly, so let's do it. But really we're focusing on psychosine because on Monday morning then GALC activity was still low, psychosine was very elevated, and the 30 kb deletion was not present. So in follow-up was initiated. Our colleagues in the Kentucky screening program acted immediately, and we had this kid referred. And the baby on Tuesday then, the 7th day of life, arrived at Duke in Dr. Kurtzberg's bone marrow transplant unit, where she then confirmed the diagnosis by collecting new specimens. Also, after talking at length with the family about the options, started the preparation for a transplant, which of course can be stopped at any moment until it actually happens. So the parents have some time to think about all of that all of the things that just hit them. And on the 9th day of life, we had the diagnosis confirmed by GALC deficiency in white blood cells, psychosine again elevated both in blood spots and in CSF, and a genotype that was a genotype of uncertain significance because it included a VUS. So in my opinion, this baby would never, without psychosine, would have received a transplant at 24 days of life. There's the baby at 100 days post-transplant, and Dr. Kurtzberg probably will tell you more about the baby in her presentation. So we have a second-tier tests for Pompe disease, MPS I, and ALD. Again, trying to reduce false positives as much as possible. For Krabbe disease, we now have 2 babies identified. We did psychosine testing 110 times through October of last year on 364,000 Kentucky babies. 2 of those were abnormal, and those both had infantile Krabbe disease. The second baby was born on a Friday of a long holiday weekend and was transplanted at 30 days of life, also out of state, but not at Duke. Both babies are alive, and I was just sent a Facebook video from the second child now walking independently. For Pompe, our second-tier test is not as perfect. So we do have a few false positives as we do for MPS I. For ALD, we don't have any false positives yet. So Joe mentioned this paper talking more about psychosine and how it can be used for screening, but also for diagnosis and maybe monitoring. And we published in here an algorithm that we feel would be appropriate and is basically describing what we do for Kentucky with the difference that we here differentiate between very elevated psychosine, as we've seen in our 2 cases, and an intermediate level of psychosine that we haven't seen yet in Kentucky, and normal, which we have seen, and then determining this is basically an emergency and you have to act very fast because we really want the transplant to happen in the first 30 days of life. And if you have an intermediate, you have more time to figure out what is really going on and seeing which and what treatment should be done with. So psychosine, when it comes to inclusivity, accumulates and based on the GALC activity. It's independent of ethnic background, so we don't have the VUS issue with a biochemical marker as we do with the molecular one. And so we would have, I think, an easier way to not just improve newborn screening, but also make it more equitable across all of our babies. The American College of Medical Genetics and Genomics has published an act sheet for infantile Krabbe disease and for the late onset form based on the psychosine levels. The difference here is that for the infantile form, there is a urgency applied and talks about the necessity to have that treatment as soon as possible if the family wants to follow through with it, which of course is something they need to decide after being informed about the options and the consequences of everything. And then the other one, again, gives you more time, but is something that also needs to be addressed. And finally, a follow-up algorithm was developed, which is very similar to the one that we published to figure out what is going on. So something that should help the primary care provider in triaging this baby appropriately. If we talk about the diagnosis of Krabbe disease, we think that psychosine in red blood cells has better, is more informative than in blood spots after newborn screening. And then leukocyte GALC activity is helpful. But just as in blood spots, you can see here, GALC activity in pseudodeficiency has some overlap, especially with the later onset variants, of which we have very few, admittedly. And you can see in infantile Krabbe disease, these patients usually have basically no activity at all. When it comes to psychosine, you can see again, infantile Krabbe disease in either specimen type is easily differentiated from normal. Also in red blood cells, the psychosine levels come a little closer to normal, but this is a logarithmic scale, so there's plenty of room here. Juvenile Krabbe disease, in the cases we have, is very abnormal. Adult Krabbe disease, and these are not babies, so these are adults. There's overlap with normal, and again, we would not know whether the newborn screening result would have been any different. And you can see here in the blood spots, again, there's total overlap for the adults, some overlap with juvenile and not with those cases with infantile, late infantile. Here's an example of a baby with a psychosine in the newborn screen of 48. Follow-up confirmed infantile Krabbe disease, and you can see here the follow-up results in red blood cells going with infantile Krabbe disease as it does in dried blood spots. And the enzyme activity, however, is at the upper end of the infantile range that we have. But based on the psychosine, there's really no question that this baby does have Krabbe disease and early onset. This is a baby where there's no second-tier test done in the screening program. You can see in red blood cells, psychosine normal. In blood spots, it's basically not present. And the enzyme activity falls well with the pseudodeficiency. And if I had the carriers here too, it would be there too. And that would be consistent. And so this baby is discharged as unaffected and could have been avoided if newborn screening had included psychosine. So this is a family that had to, the previous one, that had to consider that their baby could have Krabbe disease. And it took 2 weeks to be told, no, you're fine. Something I don't want to go through. This is a baby where the psychosine was mildly elevated in the newborn screen, had a genotype with 2 variants of uncertain significance. And this baby is monitored. The psychosine levels, again, in red blood cells also kind of in the zone where it could be maybe late infantile, but also juvenile or adult. In blood spots, a little bit helpful. And the enzyme activity also kind of in that range where you wouldn't tell the family everything is fine. But since the baby was asymptomatic and these levels are not, you need to monitor. And this finally is an adult onset case of Krabbe disease as an adult. And you can see that those values also fit with adult onset Krabbe disease. So of course, the clinical presentation in the adult patient helps you with the right decision. So in summary, newborn screening for Krabbe disease can be done in a timely fashion. Even if you do a second-tier test that has to be sent overnight somewhere. Has very few, if any, false positive results if you use a biochemical approach versus what I still believe for most is a costly and time-consuming molecular approach that, again, gives you also not always or rarely really a conclusive genotype. Accurate, highly sensitive measurement of psychosine is necessary. So this is one drawback of psychosine is that it is requires sensitive equipment that is not necessarily in every newborn screening program. So contracting with one of the 3 laboratories that currently offer psychosine in blood spots would be necessary. After a positive newborn screen for result for Krabbe disease, the laboratory diagnosis can be made based on activity in leukocytes and psychosine in the red blood cells. And the genotype can be helpful. And I think as we learn more from testing diverse populations, it probably will get better. But you also need to remember you need to do the parents' genotype because you have to make sure that the variants that are identified came from our different chromosomes. There are the follow-up guidelines from ACMG that I showed you. Dr. Stones published a paper as a lead author on the additional information guidelines on what to do when you have an abnormal newborn screen, especially for the later onset variants. And there's the council that was mentioned, and there's also Krabbe Connect. Here's from the Hunter's Hope website, the information about the advisory council that meets once a month or can meet ad hoc when necessary to help clinicians with screening results and follow-up testing that they wonder about what to do next. Krabbe Connect also provides information, especially more towards families as to what to expect and provide context to help further. With that, I would like to thank everyone in our laboratory here at the Mayo Clinic, our colleagues at the Kentucky Newborn Screening Program, Dr. GALC at the University of Washington, who started this whole newborn screening testing for lysosomal disorders, Dr. Orsini, of course, as a constant collaborator, and Dr. Kurtzberg and Hunter's Hope Foundation. And with that, I stop sharing and pass it on to Dr. Kurtzberg.
So thank you, Dieter and Joe. We're running behind, but I hope you all can stick with us for another maybe 15 extra minutes, especially so we can get to a lot of the questions that are coming up through the chat and the Q&A. I am going to speak about treatment for Krabbe disease. Second. And I want to say just hi to, I see a lot of friends going through the chat who are on the webinar, and I thank you all. It's good to see you. Let's go. Okay, you should see my screen. Now, hematopoietic stem cell transplantation is the standard of care treatment for infants with Krabbe disease who are diagnosed before significant symptom onset. And it's done with myeloablative cytoreductive chemotherapy, generally using an unrelated cord blood donor because they can be mobilized quickly and may have an advantage for CNS engraftment with the monocytes from cord blood. GVH prophylaxis is generally with cyclosporin and MMF. These kids, because they're babies, take 2 to 3 weeks to engraft. Generally, it takes 12 to 18 months for full recovery. There is a 10% or so risk of transplant-related mortality unrelated to Krabbe disease. And I think we've shown, as I'll go through the slides, that this can be done at an experienced pediatric transplant center, and referral out of state isn't necessarily required. Now, Maria Escolar and I published a paper in the New England Journal of Medicine in 2005 showing the initial outcomes of a group of babies with infantile Krabbe disease. And in those days, we didn't know that transplant before symptom onset was critical, but it was proof. So there were babies in this group who had symptoms and were in the neighborhood of 3 to 9 months of age, or babies who were newborns because of a family history and were picked up early in pregnancy and diagnosed prenatally. And what's shown in this slide for cognitive and language and motor development is that the babies who had ongoing development and improvement in these skills were the babies who were transplanted without symptoms. And generally, that was the population of babies who had had a prior sibling affected, and the family was alerted to the fact that they were at risk of having a baby with Krabbe disease. In the black lines, you can see the symptomatic babies who all had poor development post-transplant. And in fact, today we would not transplant a baby diagnosed with symptoms. In addition, in 2017, we published a retrospective analysis looking at 16 children diagnosed through family history who were transplanted at Duke either before or after 30 days of age. And we were able to see in the red bars that the children transplanted after 30 days of age had more disability, both in defects in mobility, communication, and feeding. And in green, the earlier transplants had less disability, and overall, these children were doing better. We then went to look at outcomes of early transplant in babies identified through newborn screening, and this was a collaborative study that was published in Blood Advances in 2021, and the collaborators were Duke, Nationwide, Children's Hospital of St. Louis, and Lurie Children's. It looked at babies over the last 7 years who were identified through newborn screening, so not through a family history. We looked at data that was entered into a REDCap database from each group transplanting the babies, and collected the usual data that you would do in this type of study. And we looked at a primary outcome measure of 1 year, but we have additional data in some patients, and consent was obtained from the parent and guardian after it was approved by the institutional IRB. In this initial report, there were 6 infants identified in 4 states. All of the infants had low GALC. All had very elevated psychosines ranging from 24 to 83. All were referred for transplant, 4 in their home states and 2 to Duke. All had abnormal genotypes, though to Dietrich's point, many did not have the 30Kb deletion, or at least were not homozygous for that deletion. And there were some novel variants that wouldn't have been picked up without screening with psychosine. All received cord blood transplants with myeloablative PrEP and GVH prophylaxis with cyclosporin and MMF. And I want to point out in this slide, which comes from the paper, that every baby, when studied, had abnormal neurophysiologic and neuroimaging studies. So although these babies were picked up with high psychosine and an abnormal screen, and clinically did not look abnormal, when these studies were done at a few days to a few weeks of life, their MRIs, their nerve conduction, their BAERS, their VEEPs, their EEGs, in various combinations were normal, and there were no babies without signs of active disease who were transplanted. All of these babies engrafted in a median of 13.5 days. Half had mild to moderate acute GVHD, which resolved. All children have sustained donor chimerism with a follow-up now of median of 5 years. All children have normal immune function and are off all transplant-related medications. And I'll mention that there's been an additional child identified and successfully transplanted 16 months ago, again with the mutations listed in a psychosine of 70. This child was not included in the published report. Looking at neurodevelopmental outcomes at 1 year, which are the most important, all children had some degree of motor delay or disability, but more normal language and cognitive development. And I'm going fast because of time. I also want to just alert you to another benefit of newborn screening, which is illustrated by the case I'm going to present here. There were fraternal twins born in New York who had positive newborn screens with very low GALC and intermediate psychosine. Their mutations were not associated with the 30Kb deletion, but were pathogenic. They were normal at birth and were followed quarterly for the first year of life with neuroimaging and neurophysiologic testing. And at age 15 months, MRI changes were seen first in the boy and a month later in the girl. And they also developed elevated CSF protein and abnormal nerve conduction studies. They were both transplanted at Duke at 16 months of age with the usual PrEP and supportive care. They've done well. They're now 5 years of age, going to kindergarten, and in fact have no deficits and have been evaluated by the local school authorities as not needing any kind of intervention. Dieter and Joe and I followed these kids carefully with psychosines, both in the CSF and the blood over time. And you can see their levels here. They remained intermediate, but we were using this as a barometer to try to figure out when they developed active disease. Now, going back to the 6 babies who are in the report, I want to show you that this gray bar is day 30, and 5 of the 6 were transplanted after 30 days of age, between generally 30 and 40 days of age, despite everyone's best effort. And only one, the one mentioned by Dieter, received a transplant before 30 days of age. So we still have work to do. And part of that is going to be requiring newborn screening labs and their affiliates, who either geneticists, neurologists, or pediatricians who get the results, to act very quickly when there's a baby with low GALC whose reflex testing psychosine is high. That baby should be referred to a transplant center right away. Diagnosis can be confirmed, the workup can be done, active disease can be confirmed on neurophysiologic and imaging studies, and then they can start chemotherapy early to get to transplant, hopefully around or before 30 days of age. Now, ways to help enable this are to use psychosine as second-tier testing in all newborn screening laboratories, having the labs create a roadmap for diagnosis and referral to a partner transplant center so that it's established ahead of time and you don't have to worry about making that happen in the moment. Establishing systems to obtain insurance approval rapidly. Babies are generally on their mom's policy for the first 30 days of age, but they have to be on their own policy to get a transplant approval. You can get HLA typing at the same time you send studies for disease confirmation. And you can admit the child for testing and workup to accelerate timelines. Transplant center can actually initiate chemotherapy before final selection of a cord blood unit, as long as they know there are possibilities and confirmatory testing is pending. And again, transplant won't be done unless there's signs of active disease, either by neurophysiologic or neuroimaging studies. Other emerging therapies for Krabbe disease are gene therapy, which is being explored by Forge Biologics in babies post-transplant with infantile Krabbe disease, and intraforamen magnum therapy, which is planned by Neurogene. At Duke, we're looking at cellular therapies, which may augment transplant, a cell called DUOC. And it's been mentioned, but I want to say again, there's a newborn screening task force that's been developed to help with interpretation of newborn screening results, disease classification, and recognized follow-up, or recommended, follow-up. So I'm going to stop here just mainly because of time and unshare my screen and figure out how to manage all of the questions and comments that are in the chat, which I really, really appreciate. There's lots of great conversations going on. I also want to mention that this has been recorded and it'll be available online in the next few weeks. We plan 3 additional webinars this year to continue this conversation and the education about Krabbe disease. CME credit will be available for this particular webinar if you attended through through May 2nd, 2023. So please email Anna Grantham if you have questions about any of those things. All right, now going back to questions. Did I unshare? Yes, okay. All right, I'm going to read the questions, and there's way too many for everyone to answer, but I just will get us started. There's a question that came, and I'm going to ask Joe Orsini to address this, about false positives or kids with false positive newborn screening getting a diagnosis and receiving transplant. Now, first of all, I emphasize that that does not happen, but I also wanted to give Joe a chance to address that question.
Yes, can you hear me okay, Joanne?
Yes.
Yeah, so I agree with that statement that there are really a lot of safeguards in place to prevent that from happening. I think that might be, I'm not sure where that originated, that kind of concept that maybe this is happening, but through all of the years of screening that I've been involved with in New York, I do not know of anyone that's been transplanted that didn't have some real evidence for requiring that transplant, at least that was screened through New York State. And I really haven't seen any evidence it's happened anywhere else where there's newborn screening for Krabbe disease. One thing, I mean, it's very, certain that when you have super elevated psychosine and very low Krabbe or GALC activity, that's like still such a red flag for Krabbe disease, but there's plenty of preventive measures, as you described, Joanne, with evaluation of neurodiagnostic kind of parameters that would indicate earlier onset of symptoms that you couldn't pick up necessarily through a physical evaluation.
Okay, since you're talking, one more question for you. What do you do if you have a single low enzyme in a condition that you're not screening for in a multiplex assay?
Yeah, so we, as Dietrich mentioned in his talk, we're similar. We don't look at the other enzymes unless GALC is low. And then, then we kind of open it up to look at the other, and I would consider them reference enzymes. We do know what they are, which enzymes they are, but when we see one, we've not seen where one of the other enzymes is low. It's always like the trio. There's a group of them that are low, and so it just looks like a bad sample, or I shouldn't say a bad sample. Sample with likely just low leukocytes, since most of these enzymes seem to be driven by the leukocyte counts, and especially Krabbe, the Fabry enzyme, GAA enzyme, all seem to kind of float together. So like that slide I showed, it kind of showed that that's how a baby would look too. If we see GALC at 10% of its daily mean, we're going to look and see others. If that's 10%, sometimes we'll see 10% on all the other enzymes, and we just think of that as being a bad specimen. We would have never detected them otherwise.
Dieter, a question for you. Do you have data, parentheses, ranges for psychosine and CSF?
Yeah, thanks to you and others who send us samples on patients. We do have data. We don't have a lot because, of course, we wouldn't want every baby that may have Krabbe disease to get a CSF collection. So when I'm talking about those patients, we know that we know that there are other states that don't use psychosine. They have false positives, and those babies don't get a lumbar puncture unless the initial confirmatory testing of GALC activity in leukocytes and psychosine and red blood cells was abnormal. So we have limited numbers, but we have some, and you showed some in your slides for those twins.
All right, so we are approaching 3:40. We're 10 minutes over. So I'm gonna unfortunately stop the Q&A here, but any additional questions can go to Anna Grantham by email or any of us by email. And we really thank you all for attending the webinar. I personally thank Joe and Dieter for their great talks and for speaking at this, and Anna Grantham and Melissa Jablonski for helping to set it up. We'll be in touch soon about the next webinar series. And remember, you can claim CME through May 2nd for attending this webinar, and it will be online so others can listen to it later on. So thank you all. I'm going to close the session and have a good rest of your day.
Bye.
Bye.
Bye, everyone.